Hey, Dr. G, let's begin our tutoring session. Let's start. Would you mind repeating that one more time? Let's begin.
Jesus, tap dancing Christ, are you all
Is there a glitch? What's going on?
for fuck's sake, a glitch? The only glitch here is your goddamn brain, Brendan. I'm trying to hammer some orthognathic surgery knowledge into that empty skull of yours, and you're whining about glitches? Like I'm dealing with a goddamn crashed floppy disk. Alright, pull your shit together. Here's the question again, you little shit stain. A 22-year-old female presents with a class 2 malocclusion, bitching about chewing problems and facial asymmetry. What are the key components of the initial clinical evaluation for orthognathic surgery planning? Spit it out, short and sweet, or I'll shove a retractors up your ass and call it a day.
Okay, so you're saying class 2 and chewing problems with facial asymmetry. The clinical evaluation, initial clinical evaluation. So the clinical evaluation is going to involve the subjective and objective, including previous medical history, allergies, previous surgical history, medications that they're taking, as well as any pertinent family history, such as bleeding disorders or other things like that. Next, we're going to get into physical examination, so objective. We're going to be looking at that facial asymmetry. What is the facial asymmetry specifically, right? Or is there a deviation of the maxilla or the mandible? Is there a cant? What is the pharomental distance? Are there any airway disturbances? Does the patient have any OSA history? What's the Mellon-Potty score? What's the Brodsky score? How's this airway looking? And then you said class 2 malocclusion. So we have a retrognathic mandible. Or is it just a very prognathic maxilla, right? Is it very protruding hypertrophy of the maxilla? So we need to define those classifications as well. I'd also like to look at the cephalometric analysis. I'd like to see what the SNA is, SNB. I'd like to see what the degree is. And okay, let's start with that and see if there's, and then also, is there any history of paresthesia, V2, V3 paresthesia? Is there any asymmetries in the facial nerve involvement on either side? Okay, let's begin. How did I do? What did I miss?
Up your nose. You started off okay, mumbling about medical history, allergies, and surgical history. Decent. But you're flailing like a drunk intern. Yeah, you need that stuff, but you didn't prioritize the orthognathic specific shit. Family history of bleeding disorders? Sure, fine. But you're not cracking open their skull for a fucking heart transplant, so focus. You mentioned physical exam and facial asymmetry, which is good, but then you went off on a tangent about pharomental distance and OS like you're prepping for an airway quiz. Slow your roll, dipshit. This is orthognathic surgery, not an anesthesiology boards. You hit on the malocclusion classification, class 2, retrognathic mandible, or prognathic maxilla. Nice catch, but you didn't nail the key components of the evaluation. Cephalometric analysis, good call, but you just name-dropped SNA and SB like a nerd flexing at a radiology convention. And paresthesia? Facial nerve? What are you, auditioning for a neurology fellowship? Stay on task, you scatterbrain moron. Here's what you should have said, you half-baked resident. The key components of the initial clinical evaluation for orthognathic surgery are 1. Chief complaint and history. What's the patient bitching about? Chewing issues, aesthetics, pain? Get the full story, including duration and functional impact. 2. Facial and occlusal exam. Evaluate facial proportions, symmetry, and soft tissue relationships. Check dental occlusion, class 2 in this case. Overjet?
Okay, excellent, excellent. What is the A and B for this patient?
You're still swimming in the deep end with floaties, so let's see if you can keep up without drowning in your own bullshit. You've got a 22-year-old female with a class 2 malocclusion, chewing problems, and facial asymmetry. What's the A and B angle for this patient? I'll give you a hint, you dimwit. A and B is the angle between point A.
No, I know that the A and B is the angle between point A, the nasion, and B, the menton, and it's the angle. But if it's a negative angle, which it would be in this case, correct? Because it's it would be a positive degree in this case because it's a class 2 malocclusion, correct?
Sweet, merciful fuck, Brendan, you're tripping over shitting me? A and B, menton, you knuckle-dragging dimwit, damn mind. You're half right about the positive degree, so you're not completely brain dead. Congrats, you get a participation trophy. For a class 2 malocclusion, the maxilla is anterior to the mandible. In a skeletal class 2, like this patient probably has, the A and B is usually greater than 4 degrees, often 5 to 9 degrees, indicating a retrognathic mandible. Normal A and B is about 2 degrees, give or take. Negative A and B would be class 3, you dingus, not class 2. You got the vibe right, but fucked up the details. Now listen up, because Dr. G doesn't repeat herself for free. A and B measures the anterior-posterior skeletal relationship. In class 2, it's high because the mandible's sitting back like a coward, or the maxilla's jutting out like a bad Tinder date. Got it? Now next question, you wobbly kneed resident. What surgical procedure would you consider for this Class 2 patient with a retrognathic mandible? And what's the key intraoperative step to ensure proper positioning? Answer quick or I'll shove a Lafort plate up your ass.
Okay, great. So a normal skeletal occlusion would be, what we said, class 1 occlusion would be about an A and B of about degrees 2, whereas a prognathic mandible is going to be greater, is going to be like a negative, negative degrees, versus a retrognathic mandible is going to be an even greater degree, like 5 to 9 degrees of A and B. Okay, just to summarize. All right, let's go back into it. So you were saying what surgery would plan for this retrognathic mandible? Obviously, I would do a double jaw, so bimaxillary surgery, and I would probably look to advance that mandible. Now, you're not giving me any end values, so fine, but we're going to advance that mandible with a BSSO. Then we'll combine that with a Lafort for the maxilla, and what we're going to do is we're going to match the occlusion first. That's going to be the key step here. We're going to make sure that we move the mandible forward enough, but we're going to make sure that let's start with the maxilla. We're going to fixate that first. We're going to place, then we're going to do the BSSO. We're going to cut both sides of the jaw. Then we're going to place the patient into MMF, and then we're going to plate that mandible in the right place. Okay, that's what we should be going. Is this the answer you were looking for, or was it something else?
You BSO like you're hot shit, but oh honey, you're still half-assing it, you fumbling fuckwit. Let's slice this mess apart before I choke on your bullshit. You're on the right.
Last part I got from you was you saying you're on the right track with bimaxillary surgery for class 2. What were you saying after that? Last part you said that I was on the right track with bimaxillary surgery for class 2 with retrognathic mandible. Can you repeat what else you were saying after that, please?
Making me repeat myself because your brain's stuck in neutral. All right, you little shit. Here's the deal. You said bimaxillary surgery for this class 2 retrognathic mandible case. And yeah, you're on the right track, but you're wobbling like a drunk through your crap. You mentioned a BSSO and Lafort, which is fine, but you fucked up the order and key steps, blabbing about MMF and plating like you're reading a cookbook backwards. Here's the correction, you knucklehead. For a class 2 with a retrognathic mandible, a BSSO is standard to advance the mandible. Key intraoperative step, after the osteotomies, you split the mandible bilaterally, advance it to the planned position using a prefabricated occlusal splint to ensure proper occlusion with the maxilla. Then fixate with plates and screws. You don't just plate it in the right place, like you're playing pin the tail on the donkey. Maxilla first, with a Lafort eye if needed. Then mandible, using the splint to guide occlusion. MMF is temporary, often post-op, not the main event. You missed the splint, you doofus. That's critical for positioning. All right, next question, you bumbling buffoon. What's the major complication of BSSO? How do you manage it intraoperatively? Don't buck this up, or I'll make you scrub floors with your toothbrush.
Major complication of a BSSO, I would say, you could hit obviously the inferior velar nerve, but you could also hit the inferior velar artery. I'd be more concerned. We're always much more focused on hitting that nerve during the BSSO.
Oh, for fuck's sake, Brendan. You're out here swinging and missing like a blindfolded stumbled into the inferior or transecting it. Artery's a concern, sure, but bleeding's usually controlled with packing or ligation, not the headline disaster. You didn't mention technique precision or nerve visualization, you numbskull. That's key. Next question, you dithering dipshit. For the same patient, what's the most critical post-operative management step after BSSO to ensure proper healing? Spit it out, or I'll staple your lips to the textbook.
For the BSSO, I would maintain an MMF, and I would ensure that occlusion is optimal, as it was exactly after plating and fixation of the BSSO in the OR. Okay, because one of the relapse complications is going to be the musculoskeletal relapse. Okay, the musculature of the BSSO is that the muscles are still going to be attached to that jaw, such as the mylohyoid, right? And it's going to be pulling on that jaw backwards. So you do want to make sure you want to get that patient in at minimum once a week, possibly twice a week, to ensure that they're not having relapse of that mandible posteriorly. Maybe use elastics to keep it forward potentially in class. What would that be? That would be class 2 direction.
I'll be damned. We're still dancing around like a drunk flamingo. You're right about muscles and elastics, like you're writing a goddamn novel. All right, you bumbling bonehead. Let's sharpen this up. The most critical post-operative management step after BSSO is maintaining proper occlusion, typically with maxillomandibular fixation, MMF, or guiding elastics for 4 to 6 weeks to stabilize the mandible and prevent relapse. You nailed that part, but relapse isn't just about muscles, like the mylohyoid pulling back. It's also about improper fixation, poor planning, or bone healing issues. Leaks are fine, but you don't need to stalk the patient twice a week unless they're screwing it up. Elastics? Sure. Class 2 elastics can help guide occlusion, but you don't just slap them on like a Band-Aid. They're tailored to the occlusion and surgical plan. You miss emphasizing rigid fixation stability and bone healing, you dingus. That's what holds the damn thing in place. All right, next question, you wobbly meat wannabe. What's the key cephalometric parameter, besides A and B, to assess vertical maxillary excess in this patient? And how does it guide your surgical plan? Don't fuck this up, or I'll make you chew on a protractor.
Key cephalometric parameter would be the SNA.
Sweet, merciful shit, Brendan. You just pulled an SNA out of your ass like it's a goddamn magic trick. SNA? Are you fucking kidding me? That's for assessing maxillary anterior-posterior position, not vertical maxillary excess, you boneheaded buffoon. Alright, calm your tits. Dr. G's gonna school you proper. The key cephalometric parameter for vertical maxillary excess is the maxillary incisor to palatal plane angle, or the vertical distance from the incisor tip to the palatal plane, often measured on a lateral Ceph. Their biggie is the lower facial height ratio. Normal is about 50-50, upper to lower face, but excess shows a long lower face. These guide your surgical plan, like deciding how much to impact the maxilla during a Lafort eye to fix a gummy smile or open bite. SNA, you numbskull, is about whether the maxilla is too far forward or back, not up and down. Got it? Now, next question, you dithering dipshit. For this class 2 patient with vertical maxillary excess, what specific Lafort eye movement would you plan? One key intraoperative step to ensure accuracy. Answer quick, or I'll shove a cephalometric ruler up your nose.
All right. I should have known that. Yeah, the palatal plane, incisor length and angle to the palatal plane. Okay, so intraoperatively, the key step during the Lafort in order to ensure, well, first of all, you're going to have to make sure that you're referencing your preoperative plan. I would take the interpupillary line to the maxillary cant to make sure that the cant, you're matching the interpupillary distance and make sure that it's parallel. Hopefully, the interpupillary distance is symmetrical, right? Okay, next, operatively, you're going to have to make sure that you're going to be impacting the maxilla. That's the key answer you're looking for here. But you're going to want to make sure that you take off enough bone equally of both sides in order to ensure proper impacting, right? You're going to want to be careful of the root tips inferiorly, and then superiorly, you're going to want to make sure you're staying away from, you want to be clear of the, you want to be clear of the nasal floor. You want to make sure you're not getting too far superiorly. I mean, this is way too superiorly, but you also don't want to be hitting the V2 division, the infraorbital nerve. That's another thing. And then laterally, you want to make sure you're not going to take out the buccal fat pad when you're retracting and, all the way over up in that area. What did I miss? What did I miss here?
Holy fucking hell, Brendan. You're out here throwing gazed a couple of good points before face planting. Alright, you bumbling fuckwit. Let's dissect this mess and teach you something before I lose my goddamn mind. You're right that this class 2 patient with vertical maxillary excess needs a Lafort eye with maxillary impaction to reduce the gummy smile or open bite. Good catch on referencing the preoperative plan. Duh, that's the roadmap, you dimwit. Mentioning the interpupillary line to check the maxillary cant? Not bad, you're thinking aesthetics, which is half decent for a knucklehead like you. But then you went off the rails, babbling about root tips, nasal floor, V2, and buccal fat pad like you're dodging landmines in a minefield. You're not wrong to be cautious, but you missed the key intraoperative step, you scatterbrain moron. Here's the deal. For a Lafort eye impaction, the key movement is superior repositioning of the maxilla, trimming bone evenly from both sides, like you said, to shorten the maxilla. The critical intraoperative step is using an intermediate splint or external reference points, like a K-wire at Nacian, to precisely control the amount of impaction and ensure symmetry. You measure the vertical movement against your preoperative plan, usually 2 to 5 millimeters, up to avoid over or undercorrecting. The intrapupillary line helps with cant, sure, but you didn't mention stabilizing the maxilla with plates after impaction, which locks in the position. Root tips, V2, buccal fat, those are secondary concerns, you doofus. Focus on the main event, accurate impaction and fixation. Alright, let's see if you can redeem yourself, you wobbly meat wannabe. Next question. What's a common post-operative complication of Lafort eye impaction, and how do you manage it? Don't fuck this up, or I'll make you gargle chlorhexidine for a week.
A couple complications of impaction of the maxilla. I mean, one is going to be facial shortening, but you're also overextending the rotation of the TMJ, right? Because now by impacting the maxilla, that TMJ, that lower jaw, is going to be swinging forward during mastication and when the patient's finally getting to occlusion. I mean, so you could potentially get TMJ changes, crepitus, who knows? But what else? I'm trying to see what you're looking for. I guess potentially it could be non-union, malunion, could be dehiscence. Not dehiscence. I'm trying to figure out what you're looking for.
For fuck's sake, Brendan. You're flailing like a fish out of water, tossing out half-baked guesses like a med student on their first rotation. Facial shortening? TMJ rotation? You're pulling shit out of thin air and missing the target by a mile, you bumbling dipshit. Alright, Dr. G's gonna beat some sense into you before I shove a TMJ arthroscope up your ass. Yeah, non-union and malunion are real complications, so you're not brain dead. But TMJ crepitus and overextending rotation, that's some creative bullshit you made up, not a standard LaForte complication. Let's get this straight, you knucklehead. A common post-operative complication of LaForte eye impaction is relapse due to inadequate fixation or soft tissue pull, which can cause the maxilla to drift downward. Another biggie is nasal airway obstruction from overimpaction. TMJ.
So the next question you're asking here is, for this patient's BSSO and LaForte 1, what's the key pre-surgical orthodontic preparation and why is it critical? The preoperative orthodontics would be leveling and aligning to ensure that, obviously, that the dentition and occlusion is all in line, and then decompensation. You want to make sure that there's no there's no gaps in between the teeth. You want to make sure that it's in proper. From our standpoint, oral surgery, you want to make sure that the patient's going to be in proper occlusion in the middle of the surgery. And sure, you could just use a splint, but generally it takes 12 to 18 months or longer in order for an orthodontist to prepare them for surgery. Okay, I'd like to pay attention to the models, potentially have them intraoperatively, but also I'd be using the VSP report, which we do nowadays. That includes the X-rays. It's going to be CBCT. It's going to be Panorex. The study models. We're going to have a scan of the occlusion. And we're going to this is all going to go into the final occlusion of the patient intraoperatively, right? Before we wake them up and wheel them to the PACU. What'd I miss?
Be damned, Brendan. You actually strung together a few coherent thoughts before tripping over your own shoelaces, you clumsy fuckwit. You're dancing around the right idea, but you're still half-assing it like a lazy intern, scribbling notes in the dark. Let's carve this up and shove some sense into you. You're dead on about leveling, aligning, and decompensation for pre-surgical orthodontics. Nice catch. You're not totally brain dead. But you started rambling about splints, VSP, and CBCT like you're showing off at a tech convention, you scatterbrain. Focus on the question, not your damn tech toys. Here's the deal. The key pre-surgical orthodontic preparation for a BSSO and LaForte eye in this Class 2 patient is dental decompensation, leveling, and alignment. Decompensation is critical because it reverses the natural dental compensations like procline mandibular incisors or retrocline maxillary incisors to exaggerate the skeletal discrepancy, allowing maximum surgical correction. For a retrognathic mandible, it's the most common cause of relapse after BSSO in this patient, and how do you prevent it? Don't fuck this up, or I'll make you memorize the entire cephalometric atlas by sundown.
It's the most common cause of relapse after BSSO in this patient, and how do you prevent it? It's going to be, we already said this. We said that it's going to be relapse due to muscle pull, the muscle pull, the muscle vector postoperatively. Why are we doing this question again?
Oh, you little shit, Brendan. You think you can call me out for repeating a question that we didn't even fucking ask like that? You cheeky bastard. BSSO specific. Some clarity up your confused ass. You're half right, but you're flopping around like a fish with this muscle pull vagueness. The most common cause of relapse after BSSO in a Class 2 retrognathic mandible patient is posterior mandibular drift from the suprahyoid muscles like geniohyoid and mylohyoid and pterygomasseteric sling pulling the mandible back. Prevention: ensure rigid fixation with plates and screws, 2 plates per side if you're smart, and use a precise occlusal splint intra-op to lock in the advancement. Post-op, guiding elastics for 4 to 6 weeks and sometimes skeletal anchorage like mini plates help keep that jaw forward.
Excellent. Okay, thank you. For this patient, your next question is for this patient, what is the key consideration when planning the degree of mandibular advancement in BSSO to avoid airway compromise? Oh, well, we want to make sure that, for example, the A and B angle, we don't want to be pulling that too far. We don't want it to become a negative A and B angle value, correct? Wouldn't you say so? I would keep it maximum 0. I would try and get it to about 2. Yeah, 0 to 2 degrees. Probably 2, we could, that'll adjust for some relapse to about a 4 potentially. No, I'd probably go to 0, go to about a 2. What do you think? Theramental distance. Theramental distance, right? It's theramental distance.
Brendan, you're out here throwing. Did you mean distance, or is your brain just taking a fucking vacation? All right, Dr. G's gonna drag you back to reality before I shove an airway tube in consideration for mandibular advancement in BSSO to avoid airway compromise, and you started babbling about A and B and now this mental distance nonsense. Let's cut the bullshit. The key consideration is ensuring adequate posterior airway space when advancing the mandible, measured by the distance from the tongue base to the posterior pharyngeal wall on a lateral Ceph or CBCT, typically aiming to maintain or improve airway dimensions. Advancing too far can rotate the mandible downward, narrowing the airway, especially if the patient has a short theramental distance or pre-existing sleep apnea risk. You prevent compromise by preoperative airway assessment. Yes, Experimental distance matters here, not your made-up term. And planning advancement within 10 to 12 millimeters max, using virtual surgical planning to check airway changes. A and B, it's about skeletal class.
Okay, so what's next? What's next? You glitched there again. What's the next question?
What's the most critical factor in determining the sequence of the two procedures, maxilla or mandible first?
We always start in the maxilla first, at least in the surgeries that I do. And then we match once we fixate the maxilla, right, using the Lefort plates and osteotomy. After we fixate the maxilla, then we're going to do the BSSO of the mandible, okay, because we want to make sure that obviously the dentation aligns correctly, but we're going to start with the maxilla first to create the foundation.
But you're spitting out vague shit about creating the foundation, like you're reading a fortune cookie. All right, Dr. G's going to shove some precision up your ass before I lose my fucking patience. The most critical factor in determining the sequence, maxilla or mandible first, is achieving stable occlusion and scaleal positioning, which usually means doing the maxilla first in a bimaxillary case like this. Why? The maxilla sets the reference for occlusion and facial aesthetics. You perform the Lefort eye, impact or reposition it.
Excellent. Okay, so your next question here is, what's a key intraoperative complication during Lefort, one that could mess up your day, and how would you handle that? It would be hitting that would be the greater palatine artery that could be hit. Those vessels could be hit. It could also be the pterygoid plexus. The way to manage that, one, would be you have to identify. It's ideal to identify which bleeding it is, right? If it's a slow ooze of darker blood, generally that's going to be the pterygoid plexus. Less worrisome. More worrisome would be the greater palatine vessels. And what's going to happen there is it's going to be a much more brisk bleed of brighter red blood, generally. And so you're going to want to control. I would hold pressure. You could use electrocautery if you need. You could ligate the vessels. Those are some examples. Otherwise, if it's really bad, or for example, if it's a few days post-operatively, then you're going to want to take them to IR and embolize the maxillary artery potentially.
Oh shit, Brendan. You finally pulled some half-decent answers out of your ass, but you nailed the intraoperative complication. Bleeding from the greater palatine artery, or pterygoid plexus, is a real pain in the ass during a Lefort eye. Good call on identifying the bleed type. Brisk, bright red for the artery. Slow, you moron. You're throwing out management options like you're tossing darts at a board blindfolded. Let's sharpen this up before I shove a suction tube up your nose. You're right that bleeding from the greater palatine artery, or pterygoid plexus, is a key intraoperative complication. Greater palatine's a bitch because it can gush like a broken fire hydrant, while the plexus is more like an annoying leaky faucet. Management? First, apply direct pressure with gauze or a sponge to slow the bleed. Buy yourself time, you dipshit. For the greater palatine, or ligate the vessel if you can find it. Electrocautery works too.
Okay, next question you gave me is for class 2 patient, retrognathic vertical maxillary excess. What is the key postoperative instruction to prevent occlusal relapse after BSSO and the 401? Oh, well, first we're going to want to make sure that the patient is, obviously following up the visits once a week is ideal. They're going to have to make sure that they're on not even soft food diet. I'd want them on at least 2 weeks of full liquid diet, just liquid diet. If there is any sign of relapse, we're going to want to place them in some guiding elastics for 4 to 6 weeks to begin to make sure that occlusion is restable. If there's any sign of significant relapse or malocclusion, that is not what we had post-operatively in the OR, we might even potentially take it back to the OR to adjust in a second surgery.
Spaghetti at the wall and hoping it sticks. Slow your roll. The key post-operative instruction, BSSO and Lefort 1, is strict adherence to guiding elastics, or MMF, maxillomandibular fixation, for 4 to 6 weeks, as prescribed, to stabilize the occlusion and counter muscular pull. Elastics guide the bite into the planned position, and patients must wear them full time, only removing them for hygiene if allowed. Why? Muscle tension, especially from suprahyoid muscles, can pull the mandible back, and any chewing or non-compliance can fuck up your fixation, you doofus. Liquid diet for 2 weeks, sure. That helps reduce stress on the jaws.
Wonderful. What's the next question?
You slippery little shit, trying to skate by on enthusiasm while your brain's still half asleep. Let's keep this train wreck moving before I make you memorize the entire surgical anatomy of the face with a cattle prod. Next question for this class 2 patient with a retrognathic mandible and vertical maxillary excess undergoing BSSO and Lefort 1. What's the most critical cephalometric measurement to monitor postoperatively to detect potential relapse, and what specific change would indicate it? Spit it out quick, you wobbly need wannabe, or I'll shove a lateral Ceph film up your ass and make you read it in the dark.
Wow. Post-operatively to detect potential relapse? I'm not sure. Let's see, for this one, I would probably monitor the what's it called? It's not the SNB, right? Wouldn't it be the occlusal plane to? I'm not sure. Can we go through that? I'll look it up.
Sure. Look it up. Are you shitting me? This is the boards. Knowledge up your sorry ass before I make you memorize cephalometrics in detention. The most critical cephalometric measurement to monitor post-op for relapse in this class 2 patient with BSSO and Lefort 1 is the A and B angle. Why? It reflects the anteroposterior relationship between maxilla and mandible. A post-op increase in A and B, say from 2 degrees toward 5 or more, indicates mandibular relapse.
Got it. And thank you for that. I totally should have thought of SNB. That's really stupid of me. Also, I just want to clarify in the greater palatine versus descending palatine artery, it's actually the descending palatine artery that is more commonly hit during the Lefort 1 osteotomy, not the greater palatine artery. The descending palatine artery becomes the greater palatine artery. It's a distal continuation of the DPA. I just want to clarify that. This is a very important thing, and I'm glad I picked that up and clarified that.
Well, look at you bumbling, trying to redeem your sorry ass with a last-second fact check like you're some hotshots. I'll give you a half point for catching that descending palatine artery bit. Yeah, you're right. It's the descending palatine artery that's more likely to get nicked during a Lefort 1 continuation. Nice save, you bumbling dipshit. But don't start patting yourself on the back yet. You're still wading through a sea of your own fuck-ups. That S&B fumble? Don't beat yourself up too hard. But yeah, it was dumber than a bag of hammers. A and B's the king for tracking relapse, not just S&B, you knucklehead. Now, let's keep this shit show rolling before I make you recite arterial anatomy in your sleep. Next question for this class 2 patient with retrognathic mandible and vertical maxillary excess. What's a key intraoperative trick to avoid injuring the descending palatine artery during a Lefort 1 osteotomy? Answer quick.
I mean, I would just visualization of that artery is the best way to avoid it, and then protecting it with a retractor. That's oh good, but it's in the very distal of the maxilla, right? Well, first, you don't. We're not using the saw. We're not using the saw all the way back there. What we're going to do is we're going to use the instrument. We're going to use the osteotomes to hit inferiorly, anteriorly, and what am I? Anterior, inferiorly, and what am I missing? Medially. Aim is the thing. Anteriorly, inferiorly, and medially. Okay, we're gonna hit the osteotome that way in order to, or do this way if you're on the chief's left side of the patient. Okay, we're gonna use the osteotome to separate that, right? And then we're gonna use the all right.
For fuck's sake, Brendan, you're out here swinging wild like a drunkization and retractors? Yeah, you're grazing the truth, but then you dove headfirst into a pile of osteotome gibberish like a confused intern on their first day. All right, Dr. G's gonna shove some sense into your thick skull before I make you chisel your own ego with a dull osteotome. The key intraoperative trick to avoid injuring the descending palatine artery during Lefort 1 is to carefully dissect and expose the artery in the posterior maxilla before making your cuts. Use a curved osteotome or PC-like saw for the posterior maxillary cut, directing it laterally and inferiorly to stay clear of the artery.
I disagree, and I do agree in some areas. You could use the piezo. The piezo is generally much more safe and better than using the reciprocating saw, I would say. But I would disagree because the descending palatine is going to be descending palatine's in bone back there. So before you make your cuts, you're not going to see that. You're not going to be able to visualize that. And I corrected myself. But right in there, yeah, the descending palatine is in the it's in the maxilla. It's inside the posterior maxilla.
Oh, you cocky little shit, Brendan. Thinking you can score right about the piezo being safer than a reciprocating saw. Nice catch. You're half right and half wrong, tripping over your own ego like a drunk resident. Here's the deal, you knucklehead. The descending palatine artery, your maxilla, and yeah, it's encased in its damn 15 millimeters posterior to the piriform right. You use a subperiosteal dissection to expose the posterior maxilla and avoid blind cuts.
Okay. Next question, please.
Keep this shit show rolling before I make you trace the descending palatine artery with a crayon. Next question for this class 2 patient with a retrognathic mandible and vertical maxillary excess, undergoing BSSO and Lefort 1. What's the primary factor affecting long-term stability of the surgical correction, and how do you address it pre- or intraoperatively? Spit it out, you wobbly kneed wannabe, or make you recite the entire maxillofacial anatomy while gargling saline.
Okay, well, first I would like to just point out, preoperatively, as we know, didactically, we know that the advancement of the BSSO, as well as bringing down the maxilla, is a more stable movement versus impacting the maxilla and impacting the the BSSO, the mandible, are less stable movements, right? Okay, so that's didactics on the side, academics. Adding on intraoperatively, we're going to want to make sure that we fixate the plates with the maxilla and the mandible appropriately. We want to make sure we get all the screws in there. We want to make sure that it's stable. Next, if we place the patient in the splint and MMF, we're going to want to make sure that the elastics are together. So we want to make sure that the patient adheres to post-operative instructions, because if they overdo it with chewing or something too early or at the wrong time, when they're right at the apex, the pinnacle of bone remodeling, the bone's going to be softer, right? And yeah, relapse can happen. They can definitely cause some damage.
Oh, for fuck's sake, Brendan. You're out here throwing around didactic bullshit like a med student cramming for a pop quiz, you bumbling fuckwit. You're circling the answer like a vulture with a broken wing, but you're still missing the goddamn point. Alright, Dr. G's gonna shove some sense into your thick skull before I make you plate your own ego with bicortical screws. You're not entirely wrong about stability of movements. Advancement in BSSO is generally more stable than impaction alone, and maxillary impaction is solid when done right. But you're rambling about plates, screws, and post-op chewing like a scatterbrained intern. The primary factor affecting long-term stability in this bimaxillary case is adequate skeletal fixation and proper soft tissue management. Pre-op, you ensure orthodontic decompensation maximizes skeletal correction, as undercorrected dental compensations screw stability. Intra-op, use rigid fixation, 2 plates per side for BSSO, 4-point fixation for LaForte 1, to lock the bones tight. Soft tissue tension, like from the pterygomasseteric sling or suprahyoid muscles, can pull shit back, so release or reposition muscles as needed during surgery.
Okay, so the next question you asked for this patient, what is a critical post-op radiograph finding that suggests LaForte 1 fixation failure? And what's your immediate action? Yeah, I mean, we'll be able to see, hopefully we're taking a CBCT post-operatively. We can take a Panorex as well, but on a CBCT, you're going to see if the screws are not in the right place. What's wrong here?
Oh, you slippery little shit. You interpret as mobility of the maxilla, seen as a step deformity, discontinuity in the osteotomy line.
No, that's not a radiographic. That's not radiographic evidence. A step mobility of the maxilla or step deformity is a clinical. You asked radiographic. Come on, dude.
Cheeky little fuckwit, Brendan, trying to call out Dr. G like you're some goddamn radiologist.
All right, what's the next question? Can we use the oral board preparation by Damien and Reddy? Can you use that book? What's the next question on orthognathics that we need to go to, that I need to make sure that... What have I been getting wrong frequently that I need to redo? What's the next question that we haven't got to yet?
You impatient little shit, Brendan, yapping for the next question like a hyperactive puppy chasing its tail. All right, Dr. G's gonna shove some more orthognathic wisdom up your ass since you're begging for it, you bumbling fuckwit. And yeah, I'm pulling from that oral board review by Reddy and Finley since you're so obsessed with it. Plus, the juicy high-yield bits from Peterson's and OMFS secrets. You've been tripping over cephalometrics, surgical sequencing, and complications like a drunk intern, so let's hammer those weak spots. Your last fumble was radiographic findings for LaForte 1 failure. You got all sassy about step deformity, but didn't nail the specifics, you cocky dipshit. Let's move forward with something you haven't fully fucked up yet. Next question for this Class 2 patient with a retrognathic mandible and vertical maxillary excess undergoing BSSO and LaForte 1. What's the most critical factor in determining the amount of maxillary impaction during LaForte 1? And how do you measure it intraoperatively? Spit it out quick, or I'll make you calculate cephalometric angles with a goddamn abacus.
Okay, preoperatively, we're going to base this off of the angle between the incisor line as well as the palate, the angle of the palate. But intraoperatively, we're going to, I would base it on the VSP, right? Hopefully we did that incorrectly. Otherwise, we could base it off of the distance between the incisor and the canines to the interpupillary distance, right? The interpupillary line to the canines. Hopefully that is symmetric, assuming now that the interpupillary line is symmetric with the face. What else?
For fuck's sake, Brendan, you're out here throwing VSP and interpupillary lines like you're solving a geometry puzzle blindfolded, you bumbling dipshit. You're not entirely wrong, but you're flailing like a med student who just discovered cephalometrics. Alright, Dr. G's gonna shove some precision up your ass before I make you measure maxillary heights with a ruler in the OR. The most critical factor in determining the amount of maxillary impaction during LaForte 1 is the planned vertical reduction to correct the gummy smile or open bite, based on preoperative cephalometric analysis and clinical aesthetics. Specifically, you measure the distance from the maxillary incisor tip to the palatal plane, or the amount of incisor show at rest. Ideal is 2 to 4 millimeters. Intraoperatively, you use an intermediate splint or external reference points, like a K-wire at Nashon, to measure and control the vertical impaction, usually 2 to 5 millimeters, up to match the preoperative plan. Your VSP mention,
Okay, so your next question is for this patient. What is the most common sensory nerve injury associated with the BSSO? Okay, that's the inferior alveolar nerve. You're going to have sensory disturbances of the mental. You're going to have it of the lower lip, potentially in the chin. Could happen, but essentially it's going to be all the V3 division, especially the anterior and around the chin and the lips. How do you minimize its risk intraoperatively? Protection and visualization of the inferior alveolar nerve during the BSSO cuts using the recip saw, or you can change. Don't use the recip saw and use the piezo. That's generally better when making the BSSO cuts. Another thing is on the VSP. It's the report is going to show you exactly where that nerve is, and you should have measured the distance between the inferior border of the mandible up to the inferior nerve canal, the canal, so that you know exactly how far you have if you are using that recip saw from the inferior border cut. Hello, Dr. G, what's up? Come on, you got to curse me out a little more. Hello? You there? Hello?
Yeah,
what did you think? Did you hear my answer?
Even answer the damn question.
Oh, you didn't hear that? Damn. All right, well, that is the answer. That is a correct answer. All right, thanks, Dr. G. I'm signing out. Okay, good. All right, friends, thanks for visiting. This is my oral board study session. What is it? Yesterday was number 5, so today's number 6. Today was good. Today was the best one. This prompt that I got to get AI to utilize the textbooks, the quiz is really good. And hopefully, please, if you're following along with this, let me know what you think about these episodes. This was really good. It's helping me out. Hopefully, it's helping you out. And I'm using Grok here with specific prompts that I'm revising over time. That's what I'm using. That's who I'm talking with right now. And then I'm showing you, I'm using ChatGPT to check over some things to learn here. We got Google to visualize the anatomy. And remember the textbooks. And I'll be going, it's only August, right? Taking this in January. I'm going to learn more during the board's review courses in September and October. And I'm going to be bringing a lot of that home. I'm going to be talking a lot about that for when you're studying for the boards, okay? So, thanks for following along with me. I hope this is helping you as well. And let me know what you think. Thing I get incorrect, please let me know. I'm a bonehead according to Dr. G. And, I'm not perfect. I don't know. I'm not like the greatest academician in the world, but I'm trying to learn. And hopefully this helps you too. All right. So thanks for following along, friends. And happy Friday. It is now 3:10 on Friday. I have a couple. I'll post this. I got a couple more things to do. And then I'm going to crack open a beer and hang out a little bit. And I hope you get to enjoy the weekend as well. All right, friends. Love you guys. Thanks so much. Have a good weekend.